Hello, my name is Sarah Seneff. I am a senior at the University of Arizona. My project was on a scoping review that turned into a systematic review on vaccine hesitancy with the COVID-19 vaccine. So what a scoping review turned systematic review means, that means that we started doing a scoping review and then decided we wanted to be more selective about what articles we included with the systematic review. Another key difference is that a systematic review takes longer than a scoping review. So my role in my internship was I mainly extracted information from articles that featured COVID-19 vaccine hesitancy, and then we also evaluated them for quality. The goal of the project was to gather articles on the topic, extract information, perform analysis, and gain an overall understanding of vaccine hesitancy. The Alliance for Vaccine Literacy is the team that I was working for my internship, and the team started as looking at flu vaccine hesitancy, and then the pandemic hit, and then they focused more towards COVID-19 vaccine hesitancy. The population served is the United States and the world, because addressing vaccine hesitancy not only affects the population we're looking at, but also everybody else. So the methodology, we had to come up with what we wanted each article to have. So the inclusion criteria is basically making sure that each article had what we wanted it to. So we only took articles that were a quantitative study or mixed methods. It had to include vaccine intention as an outcome, and at least one of the 5 C's included as a dependent variable. I will talk about that more on the next slide. Adult population reported separately because we wanted to focus on 18 up. US data reported separately as well, so that we could make sure we had US data to work with, since that was our primary population. English language, original data, and peer-reviewed. Okay, so more on the 5 C's. The 5 C's came from an article by Betch et al. And it was basically the main reasons why people are hesitant to get a vaccine. So confidence was the first of the 5 C's. It refers to trust and effectiveness, safety of vaccines, and the reliability of and competence of the system that delivers them. Calculation of risk is about the pros and cons. So does the reward outweigh the benefits, or does the reward outweigh the risks? And complacency refers to risk being low and people deeming that the vaccine is not necessary. Collective responsibility refers to protecting others by contributing towards herd immunity. The flip side of this could be thinking that enough people have gotten the vaccine, and so then you don't have to get it. And then constraints refers to physical or psychological barriers, including perceived and actual access to healthcare. So whether someone feels like they can go out and get the vaccine, or if they don't have access to it. Findings, we haven't actually done an analysis yet. We're working on it still. Trends that I personally noticed, though, looking through the articles, was articles that focus on certain groups of people, such as minority groups or healthcare workers. Mistrust was also a common theme of people feeling like they couldn't trust the people that made the vaccine. Healthcare workers versus non-healthcare workers was often looked at. Confidence and complacency were the more common reasons for people being vaccine hesitant. These help categorize reasons for vaccine hesitancy, and that allowed us to see that confidence and complacency were the most common. And this gives us insight on vaccine hesitancy, which is important for increasing vaccination rates. It gives us ways that we can combat it, and effective scientific methodology that allows us to come up with ways to get people to vaccinate. I want to acknowledge Maya, Purnima, and the rest of the Alliance for Vaccine Literacy team. They were all very helpful, and I would like to give a special thank you to the Western Region Public Health Training Center for this opportunity. It was truly amazing. And thank you.